Every single day, your body produces cells that, well, have the potential to kill you. And every single day, your immune system just quietly assassinates them.
It does. It's a constant microscopic war.
Right. But what happens when one of those cells learns how to, like, put on an invisibility cloak? What happens when it figures out how to forge the biochemical keys to just break out of its tissue, hijack your bloodstream, and then convince a distant organ to build an entirely new vascular system just to feed it?
Well, I mean, at that point, it ceases to be just a rogue cell, right? It becomes a systemic biological conqueror. It's a terrifying but honestly mesmerizing sequence of events.
Absolutely mesmerizing.
And, normal cells don't just spontaneously decide to become wildly aggressive carcinomas overnight. It's a spectrum, a very slow, insidious progression of microscopic changes.
Changes that completely alter the destiny of a tissue. And if you are listening to this right now, you are stepping directly into the trenches of that biological battlefield. Welcome to this deep dive.
Glad to be here for this one.
Today, we are speaking directly to you, the medical student, the one staring down the barrel of the USMLE board exams. We know exactly what you're up against, right? You're looking at a mountain of pathology slides, an endless list of pharmacological mechanisms, and it probably feels like you're drowning.
Yeah, we've all been there. You don't need a gentle overview right now. You need the high-yield, testable mechanics that are going to get you a passing score.
Exactly. And ultimately make you a far sharper clinician on the wards. So what is our mission for this session?
Our mission is highly targeted. We're going to completely deconstruct the critical concepts of oncology. We'll decode the exact timeline of neoplastic progression and dissect the dense terminology of cellular growth.
So you never mix up your adaptations with your malignancies.
Right, exactly. And then we'll thoroughly review the primary prevention and pharmacological strategies that board examiners just absolutely love to test.
So how do we make this actually stick? We're going to build this logically from the ground up. We'll start with the imitators, the benign growths and developmental anomalies that, look like cancer but really aren't.
Then we'll trace the exact molecular timeline of a cell crossing that point of no return. We'll look at how tumors physically break through barriers, how they travel, and finally, how we use pharmacology to stop them.
Along with the severe side effects those drugs carry, of course.
Of course. And we're not just going to feed you a list of facts here. The focus is on the why and the how.
Right, because if you understand the underlying mechanism, like why a nucleus looks a certain way or how a specific drug interacts with a receptor, you won't have to rely on just rote memorization.
Exactly. The answers will just become intuitive.
But, passive listening is the enemy of board prep. We need active recall. So consider us your incredibly demanding study partners today.
We're going to be throwing clinical vignettes and challenge questions your way throughout this entire discussion.
You need to lock in your answer before we keep moving. And at the end, I'll give you a highly structured day-by-day, weekly study schedule to really cement all of this. Let's get into the foundation.
Sounds good. Let's start with the basics.
Before we can even begin to talk about full-blown invasive malignancies, you really have to be able to identify the fakes. I mean, in the clinic, you're going to encounter masses that look and act suspiciously like cancer.
Yeah, they cause compressive symptoms, they show up on a CT scan, but biologically, they're something entirely different. These are your classic board traps.
Right. We're talking about developmental anomalies versus true neoplasms. Let's define the difference.
So a true neoplasm is a monoclonal proliferation of cells. It's a clonal expansion driven by acquired genetic mutations. Developmental anomalies, on the other hand, are just architectural errors.
So the cells themselves are fine.
Perfectly normal. They just didn't follow the structural blueprint during embryogenesis or maybe during tissue repair.
Let's build a mental comparison chart for this. On the left side, I want you to put two terms that always seem to just blend together in a student's mind: chorostomus and hamartomas.
Oh, yeah. Those two are always a point of confusion.
Right. Both present as a mass, both can absolutely terrify a patient, but neither of them is cancer. What exactly separates them? Let's start with the choristoma.
The defining feature of a choristoma is geographic displacement. It's a mass composed of histologically normal, mature cells, but they are located in a completely aberrant location in the body.
Like they just got lost.
Exactly. The pathology texts refer to this as an ectopic rest of normal tissue. The tissue functions perfectly well, it simply got lost during embryonic migration.
Okay, so an example that pops up a lot in practice questions is finding a nodule in the wall of the stomach. And when the pathologist biopsies it, they see perfectly normal, functioning pancreatic acinar cells and islet cells.
Yes, ectopic pancreatic tissue in the stomach, or sometimes the small intestine, is a textbook choristoma. Another incredibly common and clinically significant phenomenon that operates on a similar principle is endometriosis.
Oh, let's dive into that. Because endometriosis behaves so much like a malignancy that it really throws students off.
It does, mostly because of its clinical presentation. In endometriosis, you have endometrial glands and stroma, the functional tissue that normally lines the interior of the uterus.
Right.
But in this condition, that tissue is displaced outside the uterine cavity. It implants on the ovaries, the fallopian tubes, the broad ligament, or even the pelvic peritoneum.
And because it's structurally normal tissue, it still responds to the patient's hormonal cycle, doesn't it?
Exactly. When estrogen and progesterone levels rise and fall during the menstrual cycle, this ectopic tissue proliferates and then it bleeds.
Wow, so it's doing exactly what it's supposed to do, just in the wrong place.
Precisely. But unlike the normal uterine lining, which has an exit route out of the body, this ectopic tissue bleeds into the closed space of the pelvic cavity.
That sounds incredibly painful.
It is. It causes severe cyclical pain, intense inflammation, and eventually dense fibrosis and adhesion formation. On an ultrasound or an MRI, it can actually present as a solid mass or a cyst.
Like the classic chocolate cyst of the ovary, right?
Yeah.
Filled with old blood.
That's the one.
So it causes massive destruction of the local architecture, it causes severe pain, and it presents as a mass. It really acts like a cancer.
Clinically, yes. But if you put it under a microscope, the cells do not have mutated oncogenes driving uncontrolled division. They're just lost normal cells.
Okay, that is the choristoma. Now let's jump to the other side of the anomaly chart, the hamartoma.
A hamartoma kind of flips the script. In a hamartoma, the cells are actually in the correct geographic location. They are native to the organ.
So what's the issue then?
The error here is not location. The error is organization. A hamartoma is a haphazard, completely disorganized mass of mature, specialized cells that belong in that organ, but they just failed to arrange themselves into functional architecture.
The universally tested example here is the pulmonary hamartoma, right?
Mhm.
Walk us through what a surgeon sees versus what the pathologist sees.
Sure. So a patient gets a routine chest x-ray, and you see this well-circumscribed coin lesion in the lung periphery. It looks exactly like a primary lung tumor or maybe a metastatic nodule.
So the surgeon goes in and resects it.
Right. But when the pathologist slices it open and looks under the microscope, they don't see anaplastic carcinoma cells. They see a jumbled mass of mature hyaline cartilage, ciliated respiratory epithelium, adipose tissue, and smooth muscle.
Wait, but every single one of those tissues, the cartilage, the fat, the respiratory epithelium, that's a completely normal component of the human bronchial tree.
Precisely. The cellular ingredients are entirely correct for the lung environment, but instead of forming a functional tube to carry air, they just form this useless, disorganized lump.
So there's no malignant potential.
None. There is no malignant potential here. It is just a structural mistake.
Here's the simple analogy to lock these two into your memory for exam day. Think of a hamartoma like a highly disorganized, messy bedroom.
I like that.
Right. All the stuff in there, the bed, the clothes, the desk, the lamp, all belongs in a bedroom. It's just a total mess. The ingredients are right. The organization is wrong.
That's a great way to visualize it.
And a choristoma, on the other hand, is like walking into your kitchen and finding a fully plumbed, perfectly functioning bathtub sitting right next to the stove.
The bathtub itself is structurally perfect.
Exactly. But it is in the completely wrong room. Right ingredients, wrong location.
Bathtub in the kitchen for choristoma, messy bedroom for hamartoma. That is a highly functional heuristic. But we also need to contrast these developmental errors with true benign neoplasms.
Right, the actual tumors.
Yes, these are clonal expansions of cells, but they lack the biological capacity to invade surrounding tissue or metastasize.
They grow by expansion, not invasion. They're often encapsulated by a rim of fibrous tissue, basically pushing the normal tissue out of the way rather than destroying it.
Exactly. Let's look at the architectural terminology for these benign tumors, specifically papillomas and adenomas. Let's start with the papilloma.
Okay, what defines a papilloma?
This term describes a benign neoplasm arising from an epithelial surface. The defining characteristic is its growth pattern. A papilloma grows outward exophytically, forming multiple, delicate, finger-like or fern-like projections.
And the key histological buzzword you have to look for in a vignette is the fibrovascular core, right?
Yes, you have to know that term. Each one of those little finger-like fronds is supported by a central stalk composed of connective tissue and blood vessels. That's the fibrovascular core, which is then covered by the neoplastic but completely benign epithelial cells.
You see this classic architecture in, like, squamous papillomas of the skin or laryngeal papillomas on the vocal cords.
That's right.
And what about adenomas? This term pops up everywhere. Colon adenomas, pituitary adenomas.
Well, the suffix "oma" generally denotes a benign tumor, and the prefix "adeno" tells us the tissue of origin. An adenoma is a benign neoplasm that either arises from glandular epithelial tissue or grows in a pattern that forms glandular tube-like structures.
The sources specifically highlight a very complex-sounding adenoma that students often mistake for cancer, the pleomorphic adenoma. Let's unpack that, because pleomorphic is usually a really scary word in pathology.
It is, and it's a potentially confusing term here. The pleomorphic adenoma is the most common benign tumor of the salivary glands.
Usually presenting as a painless, slow-growing mass in the parotid gland, right, just in front of the ear.
Exactly. And the term pleomorphic here refers to the gross and microscopic architecture of the tumor itself, not necessarily malignant nuclear pleomorphism.
It's a mixed tumor, right?
Yes, it exhibits a biphasic growth pattern. It contains both epithelial components forming ducts or acini and a mesenchymal connective tissue stroma that can look myxoid, almost mucus-like, or even cartilaginous.
Wow, so it's a really mixed bag.
It's a highly variable mixed bag of tissue types, hence the term pleomorphic. But despite its varied appearance, it is biologically benign, it has a capsule, and it doesn't metastasize.
Though clinically, the surgeon has to be incredibly careful removing it. Not just because of the facial nerve running through the parotid gland, but because if they leave even a microscopic piece of the capsule behind, it can recur locally.
Local recurrence is definitely a known issue. And over many years, a long-standing pleomorphic adenoma does harbor a small risk of undergoing malignant transformation into a carcinoma X pleomorphic adenoma.
But at its baseline, it belongs strictly on the benign side of your mental chart.
Correct.
Right, you've got your foundation. You know, the messy bedroom, the bathtub in the kitchen, the finger-like papillomas, and the glandular adenomas. So put yourself in the testing center.
Time for the first challenge question.
Yep. Here we go. You are reading a clinical vignette about an incidental mass discovered on a patient's routine chest X-ray. A subsequent biopsy of this well-circumscribed lesion shows a completely disorganized, jumbled mass consisting of mature hyaline cartilage, adipose tissue, and ciliated respiratory epithelium. There is no nuclear atypia.
Pay attention to the components there.
Based on your mental chart, what is the specific pathological term for this lesion? Think about the components and their location.
The components are native to the lung, but the architectural arrangement is completely haphazard.
If you said hamartoma, you are exactly right. The messy bedroom.
Spot on.
Now that we know what a stable, benign mass looks like, let's explore what happens when normal tissue is forced to react to chronic damage. Let's look at cellular alterations.
The cells in your body are constantly being bombarded by environmental stressors. Friction, toxins, acid, sheer mechanical force.
Tough environment in there.
It really is. And how a cell population responds to that stress determines whether it adapts to survive or whether its DNA basically shatters and it starts down the pathway toward malignancy.
And this is where the terminology gets tricky for students. We need to clearly delineate metaplasia from anaplasia. They sound similar, but biologically they are on completely opposite ends of the spectrum.
Completely opposite. One is an organized evolutionary defense mechanism. The other is biological anarchy.
Let's start with the defense mechanism, metaplasia.
Metaplasia is a highly organized adaptive substitution. It's defined as the replacement of one fully differentiated adult cell type by another fully differentiated adult cell type.
So the tissue realizes it needs a change.
Basically, yes. The tissue recognizes that its current cellular lining is simply not robust enough to withstand a new, harsh environment, so it swaps out the vulnerable cells for a tougher, more appropriate cell type.
But I want to clarify something here, because this is a really common misconception. The existing mature cells don't just magically morph into a different cell type, do they? Like a squamous cell doesn't just suddenly turn into a columnar cell.
That is a crucial distinction. No, mature cells cannot change their phenotype like that. What happens is that the chronic stressor acts on the underlying reserve stem cells in the basal layer of the tissue.
Okay, the stem cells are the key.
Yes. The stressor alters the expression of transcription factors in those stem cells. So when the stem cells divide to replenish the lining, they are reprogrammed to differentiate along a new pathway, creating an entirely different mature cell type.
The ultimate, universally tested clinical scenario for this is Barrett's esophagus. Let's look at the patient history, because the USMLE won't just give you the slide, they will give you the patient's lifestyle.
Imagine a 55-year-old male who comes to the clinic. He is overweight, he smokes, and he has a 10-year history of severe, poorly controlled gastroesophageal reflux disease, or GERD.
He tells you he essentially lives on over-the-counter antacids because he constantly feels a burning sensation in his chest.
That history of chronic acid reflux is the trigger. The lower esophagus is anatomically designed as a transit tube. It's lined by stratified squamous epithelium, multiple layers of flat cells.
And that tissue is fantastic at handling the mechanical friction of a hard piece of food scraping against it as you swallow.
Right, it's great for friction. But stratified squamous epithelium is incredibly vulnerable to chemical damage. It is not designed to handle a daily bath in highly acidic gastric juices with a pH of 2.
It just burns.
The acid continuously burns and destroys the squamous cells.
So the body executes a survival protocol.
Yes. The stem cells in the lower esophagus reprogram themselves. They stop producing squamous cells and start producing simple columnar epithelium interspersed with mucus-secreting goblet cells.
Which is the exact type of tissue you normally find lower down in the intestines.
Exactly. This intestinal-type columnar epithelium is bathed in the protective mucins secreted by those goblet cells, making it vastly more resistant to the acidic environment. This highly specific metaplastic change is what we call Barrett's esophagus.
Here is the most important concept you have to commit to memory. Because metaplasia is an organized adaptation to a specific stressor, what happens if we intervene? Like, what if we give this patient a proton pump inhibitor, perform a fundoplication surgery to stop the reflux, and basically remove the acid stressor completely?
If the environmental stressor is completely withdrawn before further genetic damage occurs, the stem cells will eventually revert to their original programming.
Wow, really?
Yes, the columnar epithelium will slough off, and normal stratified squamous epithelium will repopulate the lower esophagus. Therefore, metaplasia is fundamentally a reversible process.
Reversible. Lock that word in. But wait, if it's an organized defense mechanism and it's reversible, why do we screen patients with Barrett's esophagus so aggressively? Why are we doing regular endoscopies on them?
Because while the new tissue is better at handling the acid, it is chemically out of its element. The metaplastic tissue is highly unstable.
Oh, I see.
If the acid reflux continues unabated, the constant cellular turnover and chemical stress massively increase the probability of DNA replication errors. The cells accumulate mutations, progressing from metaplasia to dysplasia, and eventually to esophageal adenocarcinoma.
So metaplasia is a survival mechanism, but it's also a blaring siren warning you that the tissue is on the brink of disaster.
Exactly. It's a warning sign.
Okay, that is metaplasia, an organized, reversible change of cell type. Now, let's look at the disaster scenario, anaplasia.
If metaplasia is adaptation, anaplasia is complete and utter chaos. Anaplasia literally means backward formation.
Backward formation.
It is the total loss of structural and functional differentiation. Anaplastic cells bear absolutely zero resemblance to the normal mature cells of the tissue from which they originated.
And that complete differentiation is a definitive hallmark of an aggressive, highly malignant neoplasm.
It is.
The sources detail very specific histological features of anaplasia. You need to know these buzzwords because the examiners will just paint a picture with them in the vignettes. Let's break down the physical characteristics of a wildly mutated cell. First, pleomorphism.
Pleomorphism indicates extreme variation in the size and shape of both the entire cell and its nucleus. In normal tissue, the cells look like a uniform army of clones.
But not here.
No. In an anaplastic tumor, you might see tiny, shriveled cells sitting right next to massive, bizarre, multinucleated tumor giant cells. There is no uniformity.
Second, let's talk about the nucleus itself. The term is hyperchromasia. Why do the nuclei look so dark?
Hyperchromasia means excessively colored. When the pathologist applies the standard H&E stain, the hematoxylin binds to nucleic acids, making them look blue.
Right.
Anaplastic cells are replicating their DNA at a frantic, uncontrolled pace. They have vastly more DNA than a normal cell, and that DNA is heavily clumped and disorganized due to the loss of normal histone regulation.
So they just soak up the dye.
Exactly. Because there is so much dense, chaotic genetic material, the nucleus takes up a massive amount of stain, appearing incredibly dark blue or almost completely pitch black under the microscope.
And that leads directly to the next feature. A drastically altered nuclear to cytoplasmic ratio, the NC ratio.
In a healthy, mature cell, the nucleus is relatively small, functioning as the quiet control center, while the cytoplasm is vast, packed with organelles doing the actual functional work of the cell. The ratio might be 1.4 or 1.6.
But an anaplastic cell doesn't care about doing the normal work of the tissue.
Not at all. It has abandoned its function. It only cares about replicating. The hyperactive nucleus swells to massive proportions to accommodate all that chaotic transcription, while the useless cytoplasm shrinks.
So what does the ratio become?
In a highly anaplastic cell, the massive nucleus takes up almost the entire volume of the cell, bringing the NC ratio close to 1.1.
You also see prominent enlarged nucleoli.
The nucleolus is the factory inside the nucleus that manufactures ribosomes. Because anaplastic cells are aggressively dividing, they need massive amounts of structural proteins.
And to build those proteins, they need ribosomes.
Right. So the nucleoli undergo immense hypertrophy to meet the demand, appearing as large, distinct, dark red dots within the dark nucleus.
Finally, there is a complete loss of cellular polarity. The cells no longer know which way is up. They don't form nice, orderly layers like the squamous epithelium, and they don't form organized circular glands.
They just grow in chaotic, destructive, disorganized sheets.
And here's the brutal reality. Because anaplasia is driven by severe, catastrophic mutations in the cell's genome-disabling tumor suppressor genes and activating oncogenes, it is entirely non-reversible.
You cannot remove the stressor and expect an anaplastic cell to turn back into a normal cell. The blueprint itself has been permanently corrupted.
So how do you keep metaplasia and anaplasia straight under the stress of an exam? Here is the simplest memory aid. Think about the prefixes.
This is a good one.
Meta means change. Think of it like changing your clothes. If you step outside into a freezing blizzard, you put on a heavy winter coat to handle the harsh environment. You adapt. But when you go back inside where it's warm, you take the coat off. You can always change your clothes back once the stressor is gone. Metaplasia is a change of clothes. It is reversible.
Perfect.
Ana means backward. You haven't just changed your clothes, you have driven your car backward off a sheer cliff. You have completely lost your original state, your differentiation, and your structural integrity. You can undrive a car backward off a cliff. The damage is permanent. Anaplasia is the backward cliff. It is irreversible.
The change of clothes versus driving off the cliff, it's slightly dramatic, but it perfectly encapsulates the biological permanence of the two states.
All right, let's put that memory aid to the test. Listener, imagine you're reviewing a pathology report for a soft tissue mass excised from a patient's thigh.
Listen for the buzzwords.
The pathologist describes the tissue as having cells with bizarre, highly variable nuclear morphology, heavily clumped chromatin, resulting in deep hyperchromasia, prominent nucleoli, a nearly 1.1 NC ratio, and absolutely zero architectural resemblance to the surrounding normal skeletal muscle.
Okay, so based on this description, is this cellular state considered reversible or irreversible?
And what's the specific pathological term for this total loss of differentiation? Think about the cliff.
The description highlights hyperchromasia, a high NC ratio, and zero resemblance to host tissue.
The answer is, it is irreversible, and the term is anaplasia. If you got that, you're tracking perfectly.
Excellent.
Now that we understand the end-stage disaster of anaplasia, we need to slow down and look at the actual timeline. How does a normal cell gradually mutate and cross over that cliff edge into cancer? Let's trace the neoplastic progression.
This is perhaps the most heavily tested conceptual area in basic oncology. The examiners want to know if you can identify exactly where a tissue is on the timeline, and more importantly, whether that specific stage is still reversible.
We will track this progression from step 1 through step 4, looking specifically at epithelial tissues, like the liming of the cervix or the colon.
Step 1 is the baseline normal tissue. In a normal, healthy epithelial layer, you have perfect order. Let's use the cervical squamous epithelium as our model.
Okay, paint the picture.
At the very bottom, resting on the basement membrane, you have a single layer of dividing basal cells. As these cells divide, they get pushed upward toward the surface. As they move up, they mature.
They flatten out, their nuclei shrink, and they accumulate glycogen.
Yes. This is called basal to apical differentiation. The cells stick tightly together, they respect their boundaries, and the NC ratio is small and uniform.
But then our tissue encounters chronic stress. Maybe it's inflammation or perhaps an infection with high-risk human papillomavirus, HPV. We move to step 2, hyperplasia.
Hyperplasia is a quantitative change, not a qualitative one. It is simply defined as an increased number of cells.
So the tissue just gets thicker.
The tissue layer becomes thicker because the cells are proliferating at a faster rate in response to a stimulus. However, if you look closely at those individual cells, they still maintain normal histology. They still differentiate properly from bottom to top.
A great example of this is the thickening of the endometrium during the menstrual cycle in response to estrogen, or the development of a callus on your hand from lifting weights. It is an adaptation.
Exactly.
And I want to emphasize this heavily because the cells themselves are not fundamentally mutated. Hyperplasia is absolutely reversible. If you stop lifting weights, the callus fades. If you clear the infection, the tissue thickness returns to normal.
But if the oncogenic stimulus, like the viral proteins from HPV, persists, the cells are forced into constant replication. With every replication cycle, the chance for a DNA copying error increases. The tissue crosses a threshold and enters step 3 dysplasia.
Dysplasia is where the alarm bell should be ringing. It translates to bad growth. We have moved beyond simple adaptation and into genetic instability.
In dysplasia, you still have an overproliferation of cells, but now the cells themselves look wrong. They are acquiring mutations. We begin to see a loss of normal cellular orientation.
That beautiful, orderly, basal to apical maturation starts to fall apart.
The nuclei becomes enlarged and slightly hyperchromatic. The NC ratio begins to rise.
We actually grade dysplasia based on how far up the epithelial layer these abnormal cells have reached.
Yes, going back to our cervical model, this is the CIN grading system, cervical intraepithelial neoplasia. If the abnormal dysplastic cells are only found in the bottom 1/3 of the epithelial layer, we call it mild dysplasia, or CIN1.
And if they reach 2/3 of the way up,
That's moderate dysplasia, or CIN2. If they occupy almost the entire thickness but not quite, it's severe dysplasia, CIN3.
here is the massive trap that students fall into on exam day. An examiner will describe a biopsy showing moderate dysplasia with atypical nuclei and loss of polarity and ask you about the prognosis.
This is crucial.
Listen closely. Even at the stage of severe dysplasia, where the cells are highly mutated and disorganized, this step is theoretically still reversible.
It's counterintuitive but true. The tissue is teetering on the very edge of the cliff. But if the patient's immune system finally mounts a response and clears the HPV infection, or if a chemical carcinogen is completely removed, the damaged dysplastic cells can be naturally shed from the surface.
And they get replaced by healthy cells migrating up from unmutated stem cells. Reversibility is still possible, though less likely the higher the grade.
But then the final mutations occur. The tissue takes that last step over the edge. Step 4, carcinoma in situ.
Carcinoma in situ, or CIS, translates to cancer in its place. This is stage 0 disease. At this point, the biological line has been crossed.
The cells have acquired the full suite of malignant histological features. They are completely anaplastic. They have a massive NC ratio, bizarre pleomorphism, and dark, heavily clumped chromatin.
And structurally, how does it differ from severe dysplasia?
In CIS, these wildly atypical malignant cells now span the absolute entire thickness of the epithelial layer, from the very bottom basal layer to the very top apical surface. There is zero normal tissue left in that vertical segment.
Wow, the whole layer is corrupted.
Because the entire thickness is composed of fully mutated anaplastic cells, there are no healthy stem cells left to regenerate the tissue. Therefore, carcinoma in situ is entirely definitively non-reversible.
The car is driven off the cliff. But here is the massive critical caveat. Why do we call it stage 0? Why is it in situ?
Because despite looking exactly like lethal invasive cancer cells under the microscope, the tumor has a physical limitation. Underneath every epithelial layer is a tough, fibrous sheet of connective tissue called the basement membrane.
The wall.
In carcinoma in situ, that basement membrane remains perfectly intact. It is an unbroken wall. The malignant cells are entirely confined to the superficial epithelial layer where they originated.
I always think of CIS like a massive riot inside a maximum security prison. The inmates, the wildly mutated violent cancer cells, have completely taken over the cell block. They have killed the guards. They are rioting from the basement to the roof. Total anarchy inside.
But the outer perimeter wall.
Exactly. The outer perimeter wall of the prison, the basement membrane, is still holding strong. Not a single inmate has breached the wall.
And because they haven't breached the wall, they cannot access the surrounding connective tissue stroma. This is clinically vital because blood vessels and lymphatic channels are located in the stroma, not in the epithelium.
Because the tumor cells cannot reach the blood supply, a carcinoma in situ, by biological definition, cannot metastasize. It is localized, trapped cancer.
The classic clinical presentation of this that you must know is DCIS, ductal carcinoma in situ of the breast.
Right. In DCIS, the malignant epithelial cells proliferate and completely fill and distend the microscopic ducts of the breast. It can cause calcifications that show up on a mammogram.
But if you look microscopically, the basement membrane of the duct is unbroken. The cancer is trapped inside the pipes. It's a highly curable stage if surgically resected, because we know with certainty it hasn't entered the bloodstream.
Okay, that is the definitive timeline. Normal to hyperplasia to dysplasia to carcinoma in situ. Let's do a rapid-fire check on these concepts before the formal challenge.
Let's do it.
I'm going to throw out a brief histological description, and listener, I want you to name the step on the timeline before the expert gives the answer. Ready? You see an increased number of cells, but they maintain completely normal architecture at maturation. What step?
That is hyperplasia.
You see a loss of cellular orientation, slightly darkened nuclei reaching halfway up the epithelium, but the process is still theoretically reversible. What step?
That is dysplasia.
You see highly anaplastic cells with severe chromatin clumping spanning the entire thickness of the epithelium. It is non-reversible, but the basement membrane underneath is entirely unbroken. What step?
Carcinoma in situ.
Nailed it. Now for the clinical challenge question. Put yourself on the wards. A 35-year-old woman with a history of persistent high-risk HPV infection undergoes a colposcopy after an abnormal pap smear.
Okay.
A biopsy of her cervical tissue reveals severely atypical cells with a high NC ratio, pleomorphism, and prominent nucleoli. These highly abnormal cells span the entire thickness of the squamous epithelium, from the basal layer to the surface.
That's key.
However, special immunohistochemical stains confirm that the underlying basement membrane is completely continuous and unbroken. What is the exact diagnosis? And based on the biological features, is this state considered reversible or non-reversible? Think about the prison riot.
The cells span the entire thickness and the basement membrane is unbroken. The genetic damage is complete.
The diagnosis is carcinoma in situ, and it is non-reversible. You are doing fantastic. Now, the obvious question is, how does the cancer break out of the prison? Let's move to the mechanics of invasion.
Carcinoma in situ is trapped, but tumors are driven by relentless evolutionary pressure to expand, consume resources, and seat a blood supply. Eventually, a subclone of those trapped cells will acquire further mutations that grant them the specific biochemical tools needed to physically break through that intact basement membrane and enter the underlying stroma.
This is the moment a localized lesion becomes an invasive carcinoma. This changes everything. It changes its growth pattern, its lethal potential, and its clinical presentation.
And the USMLE board examiners do not just want to know that it invades, they demand that you know exactly how it invades at the protein level.
Right. There is a specific molecular triad, a sequence of 3 vital events, that allows a tumor cell to break out. Let's walk through them.
The first step is detachment. Normal epithelial cells are highly social. They are tightly bound to their neighbors, communicating and holding on to each other using cellular adhesion molecules. The most important of these in epithelial tissues is a transmembrane protein called E-cadherin.
E-cadherin is the biological superglue holding the inmates together inside the prison.
Exactly. And as long as a tumor cell is glued to its neighbors, it cannot migrate. So the first critical molecular event is that the invasive tumor cell downregulates or mutates the expression of E-cadherin.
By breaking these intercellular junctions, the individual tumor cell untethers itself from the primary mass. It becomes a free agent.
Step 1, downregulate E-cadherin, let go of your buddy. But now the cell is floating loose in the cellular matrix. It needs traction to move forward toward the basement membrane. How does it crawl?
That brings us to step 2, attachment to the extracellular matrix, or ECM. The basement membrane and the stroma below it aren't just empty space, right? They are a dense physical web of structural proteins, primarily laminin, fibronectin, and collagen.
Yes, the tumor cell must physically grab onto the structural web to pull itself forward. It does this by massively upregulating the expression of specific receptor proteins on its cell surface, specifically laminin and integrin receptors.
Let's use an analogy here to visualize this. Think of the individual tumor cell as a free solo rock climber trying to scale a cliff face. First, the climber has to let go of the hand of the climber next to them. That is downregulating E-cadherin.
Oh, wait, I see where you go.
Then the climber has to reach out and grab the physical handholds jutting out of the rock wall to pull themselves forward. The handholds on the rock wall are the laminin and fibronectin proteins in the extracellular matrix, and the climber's hands. Those are the upregulated laminin and integrin receptors on the surface of the tumor cell.
That is a perfect visualization. Let go of the neighbor, grab the wall, But now our climber has reached a solid, impenetrable physical ceiling, the dense collagen web of the basement membrane itself.
You cannot just squeeze through a brick wall. You have to destroy it. Which brings us to the final destructive step of the triad. The cell needs a weapon. It needs a biochemical machete.
Precisely. The tumor cell upregulates and secretes a specific class of powerful zinc-dependent proteolytic enzymes called matrix metalloproteinases, or MMPs.
The machete.
These enzymes are the machetes. They act like highly targeted chemical scissors. The MMPs specifically digest and degrade the tough type 5e collagen and lamin that make up the basement membrane and the interstitial connective tissue.
So let's summarize the prison break triad. The cell downregulates E-cadherin to get loose. It upregulates integrin receptors to grab onto the matrix. And then it secretes massive amounts of MMPs to chemically chew a hole straight through the basement membrane.
Once it squeezes through that hole, the disease is officially an invasive carcinoma.
And once that tumor breaches the wall and invades the underlying stroma, the host tissue doesn't just ignore it, right? The body detects the destruction and the invading foreign cells, and it mounts an aggressive structural reaction.
The local host connective tissue responds to the infiltrating neoplastic cells in a process called desmoplasia.
Desmoplasia. This is a massive buzzword that bridges pathology and physical diagnosis, what is actually happening in the tissue.
Desmoplasia is an intense, robust, fibrous connective tissue response to neoplastic invasion. As the tumor cells secrete growth factors and MMPs, they recruit and activate normal host fibroblasts to the area.
And what do the fibroblasts do?
These fibroblasts go into overdrive, churning out massive amounts of dense collagen and extracellular matrix. The body is essentially trying to wall off the invading tumor by burying it in thick, heavy scar tissue.
This molecular tug-of-war translates directly to a classic physical exam, finding that you will absolutely feel on the wards and read in board questions. Let's contrast the physical feel of a benign growth with a desmoplastic invasive carcinoma.
A very common clinical scenario.
If a patient has a benign fibroadenoma in their breast, you palpate it, and it feels like a smooth, rubbery, slippery marble. It is encapsulated. It slides around under your fingers because it is cohesive and non-invasive.
But if a patient has an invasive ductal carcinoma, the tumor is actively destroying tissue. It sends out microscopic tentacles into the stroma, looking almost like a crab extending its claws.
And the resulting desmoplasia, that massive, chaotic dumping of dense fibrous scar tissue by the host, makes the tumor feel incredibly firm, rock hard, and completely fixed to the surrounding tissue. It doesn't move.
And if a surgeon resects a highly desmoplastic tumor, like a serous carcinoma of the breast or a pancreatic adenocarcinoma, and they slice it open with a scalpel, the pathology texts describe it as having a firm, gritty consistency.
Like cutting through an unripe pear,
Right.
or a water chestnut.
Exactly. That rock-hard, gritty presentation is the direct macroscopic consequence of the microscopic desmoplastic reaction.
Let's lock in this molecular triad. It is time for the clinical challenge question. Imagine a massive pharmaceutical company is investing billions to develop a novel, targeted cancer therapy. Their goal is to create a drug that specifically arrests tumor progression right at stage 0.
So they want to keep it in situ.
They want to stop a mutated in situ tumor cell from chemically dissolving and breaching the basement membrane, preventing it from ever becoming invasive. To achieve this specific goal, which class of upregulated enzymes should their new therapeutic drug target and inhibit? Think about the chemical scissors.
We are looking for the enzymes responsible for degrading the type 5e collagen of the basement membrane.
The answer is matrix metalloproteinases, or MMPs. If you got that, your molecular pathology is solid. Now, let's follow the tumor into its most lethal phase.
We have crossed into the final frontier distant metastasis. Once the invasive carcinoma has breached the basement membrane, established itself in the local stroma, and triggered that desmoplastic reaction, it gains access to the host's vascular and lymphatic systems.
This initiates the terrifying, highly complex pathway of how these malignant cells spread to form secondary, deadly tumors in distant organs.
The journey a tumor cell takes through the bloodstream is essentially a biological gauntlet. It is a suicide mission for most of them. Millions of tumor cells might enter the blood, but only a tiny fraction survive to form a metastasis.
But the ones that do survive have mastered a very specific, testable sequence of events.
The journey begins with intravasation. As the invasive tumor degrades the local stroma, it eventually encounters host blood vessels or thin-walled lymphatic channels. The tumor cells utilize those exact same matrix metalloproteinases to chew through the endothelial lining of the vessels and squeeze into the circulatory system.
Now they are floating in the bloodstream. But the blood is a profoundly hostile environment. First, there is immense mechanical shear stress from the pumping fluid. The physical force of the blood can literally rip a fragile tumor cell apart.
And more importantly, the host immune system is waiting. Natural killer cells and cytotoxic CD8 plus T cells are actively patrolling the circulation, actively scanning for foreign, mutated, or misplaced cells to destroy. The isolated tumor cell is completely exposed.
To survive this gauntlet, the tumor cell must hide. It has to deploy an invisibility cloak.
Once in the circulation, the isolated tumor cells rapidly interact with normal host components. They express procoagulant factors like tissue factor, which causes the host's own platelets to aggregate around them. They also bind to circulating host lymphoid cells.
The result is a microscopic clump traveling through the blood, known as a tumor cell embolus.
This is an incredibly devious, elegant survival mechanism. The tumor cell literally coats itself in a thick layer of the patient's own platelets and immune cells.
So when the patrolling natural killer cells pass by, they don't see the foreign tumor cell antigens, they just see a clump of normal host-derived platelets.
Exactly. The tumor uses the host's own tissues as an invisibility cloak to evade immune destruction while it rides the circulatory current.
But it can't ride the current forever. Eventually, this bulky tumor embolus will get carried along until the blood vessels narrow. It will travel until it physically wedges into a capillary that is simply too small for it to pass through. It arrests in a distant capillary bed.
And this mechanical arrest is largely dictated by the anatomical flow of venous blood. Blood draining from the gastrointestinal tract must first pass through the portal vein into the massive capillary beds of the liver.
Right.
Venous blood from the rest of the body ultimately returns to the right heart and is pumped into the capillary beds of the lungs. This basic plumbing explains why the liver and the lungs are, overwhelmingly, the most common sites for distant metastatic deposits.
So the tumor embolus is wedged in a lung capillary. But being trapped inside a tiny blood vessel isn't a tumor. It has to get back out into the tissue.
This is the process of extravasation. It is essentially the reverse of intravasation. The tumor cell adheres to the endothelial lining of the capillary, secretes enzymes to degrade the basement membrane of the vessel from the inside out, and squeezes out into the parenchyma of the new organ.
In this case, the soft, oxygen-rich tissue of the lung.
Yes, it has arrived. It has survived the journey. It starts to divide. But there is one final massive hurdle.
A tiny, microscopic deposit of a few hundred tumor cells can survive by simply absorbing nutrients from the surrounding fluid. But once that nodule grows to about 1 to 2 millimeters in size, it hits a physical limit.
The center of the mass becomes hypoxic. The cells in the middle are too far away from the host blood vessels to receive oxygen, and they will start to necrose and starve. To grow into a clinically significant, life-threatening mass of a centimeter or more, the metastasis must establish its own dedicated blood supply.
The tumor has to build its own plumbing.
The final critical requirement for the survival and explosive growth of a metastasis is the induction of angiogenesis. The hypoxic metastatic cells upregulate transcription factors like HIF-1 alpha, which causes them to secrete powerful chemical signals, most notably vascular endothelial growth factor, or VEGF.
VEGF is the signal that tricks the body.
Yes, VEGF diffuses out and stimulates the normal, healthy host endothelial cells in nearby blood vessels. It forces them to sprout new capillaries that grow directly toward and into the tumor mass,
Providing that endless supply of oxygen and nutrients.
This new, albeit chaotic and leaky vascular network, provides what is required for the metastasis to rapidly expand and eventually threaten the organ's function.
It coerces the distant organ into feeding it. And because of how this process happens, with thousands of tiny tumor emboli showering the organ simultaneously from the bloodstream, metastatic disease has a very specific presentation on a CT scan or an X-ray.
It does.
Earlier, we noted that a primary invasive carcinoma, like a breast cancer or colon cancer, typically presents as a single, large, deeply infiltrating, firm mass. But how does a metastatic shower present?
Because multiple emboli rest in multiple different capillary beds across the organ at roughly the same time, metastasis classically presents as multiple, well-circumscribed nodules scattered diffusely throughout the secondary organ.
In the lungs, for example, you will see dozens of large, distinct spherical metastatic nodules that radiologists classically describe as cannonball lesions.
Right, if you look at imaging of a liver or a lung and it is studded with a dozen distinct masses, you are almost certainly looking at metastatic disease that has arrived via the blood, rather than a primary tumor originating in that organ.
Single ugly mass usually equals primary, multiple distinct nodules equal metastasis. All right, let's test this journey. Here is challenge tune. Question number 5. Listen closely to the exact phase of the journey.
Let's hear it.
After an invasive tumor cell successfully secretes MMPs and intravasates into the venous circulatory system, it is highly vulnerable to shear stress and immediate immune clearance by natural killer cells. What specific host components does the isolated tumor cell aggressively aggregate with to form a protective embolus, effectively acting as a biological invisibility cloak to evade immune detection before it finally arrests in a distant capillary bed? Think about what it uses to hide.
It curled itself in normal circulating host components to mask its foreign antigens?
The answer is platelets and host lymphoid cells. If you remembered the platelets forming the cloak, you have mastered the metastatic pathway. We have covered the microscopic horrors of how this disease grows, mutates, and spreads. Now we enter the final act.
We must shift our focus from pathology to actionable clinical intervention. The final segment of our deep dive focuses on primary prevention, understanding patient history, and the highly testable pharmacology that you will be prescribing and managing the side effects of on the wards.
Prevention is the absolute holy grail of oncology. If we can stop the mutations before they start, we win. The sources break this down into lifestyle modifications versus active chemoprevention with drugs. Let's start with lifestyle.
It sounds like basic primary care advice, but the epidemiological impact and the mechanisms are incredibly high yield.
When we look at the absolute numbers, the contributory factors responsible for cancer in the United States, smoking is undeniably overwhelmingly number 1. It is the leading cause of preventable cancer-related mortality.
And the mechanism is direct chemical mutagenesis. The thousands of carcinogens in tobacco smoke, specifically polycyclic aromatic hydrocarbons, or PAH, are absorbed and metabolized into highly reactive electrophiles.
And those electrophiles seek out DNA.
Exactly. They physically bind to the DNA in the epithelial cells of the airway, forming DNA adducts. This causes transversions and copying errors during replication, specifically crippling crucial tumor suppressor genes like P53.
So smoking cessation isn't just about preventing COPD or emphysema. It is the single most effective primary prevention modality to abruptly halt the accumulation of these DNA adducts. It drastically reduces the massive risk of squamous cell and small cell lung cancers, as well as laryngeal and urothelial bladder cancers.
Similarly, sweeping dietary changes have a profound, direct mechanistic impact on specific organ systems, particularly the GI tract, increasing dietary fiber and drastically decreasing saturated animal fats targets, and significantly lowers the risk of colorectal cancer.
How exactly does fiber stop colon cancer? I mean, it's not just a vague wellness concept.
No, it alters the mechanical and chemical environment of the bowel. High fiber intake increases fecal bulk and speeds up the mechanical transit time of stool through the colon.
Okay, so it moves faster.
Yes. Saturated fats cause the liver to secrete massive amounts of bile acids, which gut bacteria convert into secondary bile acids, known mucosal irritants and potential carcinogens.
By speeding up transit time, the fiber severely reduces the amount of time these irritating bile acids and ingested carcinogens are in physical contact with the vulnerable colonic mucosa.
Exactly. Less contact time equals less cellular stress, less hyperplasia, and fewer mutations.
That is the lifestyle side. Now let's get into the heavy pharmacology chemoprevention. Using active medications to alter the tissue environment and prevent cancer from forming. The first agent is surprisingly simple, something you can buy at a gas station: aspirin.
It is a remarkable piece of data. Extensive epidemiological studies show that chronic daily use of aspirin, a simple non-steroidal anti-inflammatory drug, or NSAID specifically, and significantly decreases the incidence of several gastrointestinal malignancies.
Most notably, esophageal, stomach, and colorectal cancers.
And the mechanism here is tied to its primary target, the COX enzyme.
Correct. Aspirin irreversibly inhibits the cyclooxygenase enzymes, specifically KOX2. It turns out that KOX2 is heavily overexpressed in colonic adenomas and colorectal carcinomas.
By blocking COX2, aspirin chronically reduces mucosal inflammation and decreases the production of certain prostaglandins that promote cellular proliferation and angiogenesis.
By shutting down that inflammatory proliferative signaling pathway, aspirin acts as a powerful preventative agent against the progression of polyps to cancer.
But the pharmacology gets infinitely more complex and much more heavily tested on the USMLE when we look at targeted hormonal therapies. We have to talk about tamoxifen.
This is a drug you must know inside, outside, and backward.
Tamoxifen belongs to a unique class of drugs called selective estrogen receptor modulators, or SERMs. It is an absolute staple in the pharmacological arsenal for patients with estrogen receptor-positive breast cancer.
But the absolute key word to focus on here is selective. Its molecular mechanism of action completely changes depending on the specific tissue environment it is interacting with.
Right. It behaves like a biochemical skeleton key.
Yeah.
Let's look at the breast tissue first. In normal breast tissue and in ER-positive breast cancer cells, tamoxifen acts as a strict competitive antagonist.
So it blocks it.
It physically binds to the estrogen receptor in the cell's cytoplasm, taking up the parking spot, but it does not activate the receptor. More importantly, it physically blocks circulating estrogen from binding.
If the breast cancer cells are addicted to estrogen signaling to drive their replication, tamoxifen effectively cuts off their fuel supply.
Exactly. So it is prescribed to treat active breast cancer, but also as a powerful chemopreventative to reduce the risk of a second primary malignancy developing in the remaining breast tissue of a survivor, or to lower the incidence in high-risk women with a strong family history who haven't had cancer yet.
It is a lifesaver in the breast. But what happens when that exact same drug circulates down to the uterus?
That selectivity shows its dark side. While tamoxifen acts as an antagonist and recruits co-repressor proteins in the breast, it encounters a different set of cellular co-activators in the endometrium, the lining of the uterus.
In the endometrial tissue, tamoxifen acts as a partial agonist.
Yes. It binds to the estrogen receptor in the uterus and actually turns it on.
Wow.
It actively stimulates the endometrial cells to proliferate. And as we discussed with the timeline, chronic, unremitting stimulation leads to endometrial hyperplasia.
That hyperplasia can progress to dysplasia, and ultimately, it significantly increases the patient's risk of developing endometrial adenocarcinoma. You are actively starving one potential cancer in the breast, but actively feeding the risk of another cancer in the uterus.
And the side effect profile doesn't stop there. Tamoxifen also interacts with the liver. Just like natural estrogen, tamoxifen acts as an agonist in the liver, stimulating the hepatocytes to massively increase the synthesis of procoagulant clotting factors.
This creates a hypercoagulable state, leading to another severe, life-threatening side effect. It significantly increases the risk of serious thromboembolic events, specifically deep vein thrombosis or DVT in the legs, which can break off and become a fatal pulmonary embolism in the lungs.
This is a guaranteed board scenario. You'll read a vignette where a woman who successfully beat breast cancer 3 years ago and is taking a daily preventative pill suddenly shows up to the emergency room with a red, swollen, intensely painful calf, or she complains of sudden, abnormal postmenopausal vaginal bleeding.
The underlying culprit they are testing is almost always tamoxifen. Now, let's look at one final heavily regulated preventative drug, isotretinoin, historically known under the brand name Accutane.
Isotretinoin is a powerful synthetic derivative of vitamin A. It binds to retinoic acid receptors in the nucleus to heavily alter gene transcription. In the context of oncology and prevention, it is used to induce differentiation.
It can decrease the formation of leukoplakia, those white, hyperkeratotic precancerous patches in the lungs and the GI tract.
It forces rapidly dividing, confused cells to mature and differentiate properly. It is also a critical curative treatment for a specific blood cancer, acute promyelocytic leukemia, or APML.
In APML, immature leukemic blasts get structurally stuck and multiply uncontrollably. High-dose isotretinoin forces those stuck blasts to finally mature and differentiate into functioning neutrophils, essentially curing the leukemia by forcing it to grow up.
But the USMLE rarely tests the cure, they test the collateral damage. Isotretinoin has a systemic, brutal toxicity profile because vitamin A receptors are everywhere in the body.
The side effects are severe and highly testable. Because it alters cellular turnover, it can cause premature epiphyseal plate closure in teenagers, leading to stunted growth. It causes severe hypertriglyceridemia.
It can induce violent inflammation of the liver and pancreas hepatotoxicity and pancreatitis. It also carries serious psychiatric warnings, including severe depression and an increased risk of suicidal ideation.
But the absolute non-negotiable most critical danger of this drug involves pregnancy.
Isotretinoin is one of the most potent teratogens known to medicine. If a woman takes this drug during pregnancy, it alters the fundamental embryonic transcription pathways, causing massive, catastrophic, and often fatal developmental birth defects in the fetus, particularly cranial and cardiac malformations.
Because of this profound danger, the FDA refuses to let this drug be prescribed normally. It requires enrollment in a strict, computerized regulatory system called the IPLU-GH program. Let's frame this as a practice question for our listener right now.
Good idea.
If a 24-year-old female patient is prescribed oral isotretinoin, either for severe nodulocytic acne or as a chemopreventive agent under the federal IPLU-GH program, what strict absolute requirements must be met and formally documented by the physician before she can even pick up her first prescription and maintain throughout her entire treatment course?
Think about the extreme risk to a potential fetus. The regulatory program is designed to guarantee with absolute certainty that there is zero chance of a fetus being exposed.
The required answer is, she must commit to using 2 simultaneous independent forms of effective birth control, and she must have a negative pregnancy test administered and documented by a healthcare provider every single month before the pharmacy will release the next 30-day supply.
Absolute critical to know.
All right, let's wrap up this complex pharmacological deep dive with our final comprehensive challenge question. A 62-year-old postmenopausal female patient with a history of estrogen receptor-positive breast cancer has been taking a specific daily oral chemopreventative agent for the past 3 years to prevent cancer recurrence.
Okay, keeping track of the history.
She presents to your clinic today highly distressed, complaining of sudden onset right leg swelling and deep calf pain. During the review of systems, she also mentioned she's been experiencing unexpected abnormal uterine bleeding for the past 2 months. Based on this clinical presentation, what specific drug is she taking, and what is its exact molecular mechanism of action in the uterus that is causing the bleeding? Think about the skeleton key.
The patient is simultaneously experiencing a DVT and likely endometrial hyperplasia. The drug has dual tissue-specific effects.
The drug is tamoxifen, and its precise mechanism in the uterus is that it acts as a partial agonist at the endometrial estrogen receptors, stimulating uncontrolled proliferation.
Great job if you got that one.
We made it. We have systematically deconstructed the foundation of oncology, from the messy bedroom of the hamartoma, through the broken basement membrane of invasion, all the way to the dual-edged sword of pharmacology.
But understanding it once is not enough for the boards. As promised at the very beginning of this deep dive, we are going to leave you with a highly structured, rapid board prep weekly study schedule.
This is designed to utilize spaced repetition to cement these complex molecular pathways into your long-term memory so they become instant recall on exam day. If I were sitting for the USMLE right now, here is exactly how I would structure my week based on what we just discussed.
Take notes on this.
Monday. Your sole focus is the foundation and terminology. Redraw the mental comparison chart we built. Write out the exact architectural differences between hamartomas, the messy bedroom with right ingredients, wrong organization, and choristomas, the bathtub in the kitchen, right ingredients, wrong place.
Then, lock down the terminology. Draw a hard line down a piece of paper. On the left, write reversible and list metaplasia, the change of clothes, and dysplasia. On the right, write irreversible and list anaplasia, driving off the cliff, and carcinoma in situ.
Tuesday, master the timeline. Take a blank whiteboard and draw out the 5 steps. Normal, arrow to hyperplasia, arrow to dysplasia, arrow to carcinoma in situ, arrow to invasive carcinoma. Circle dysplasia and write still reversible. Under carcinoma in situ, draw a thick, solid red line and write in massive letters intact basement membrane.
Wednesday, focus purely on the biochemical prism break, the molecular mechanics of invasion. You need to memorize the triad cold. Use the rock climber analogy. Let go of the neighbor. Downregulate E-caterin. Grab the wall. Upregulate laminin and integrin receptors. Use the machete to break the wall. Upregulate and secrete matrix metalloproteinases.
Thursday, map the metastatic pathway. Write down the sequence of the journey. Intravasation, evasion of the immune system via the platelet and lymphoid invisibility cloak, mechanical arrest in the capillary beds of the liver or lungs, extravasation into the tissue, and finally the induction of angiogenesis via VEGF to avoid starvation.
Friday Pharmacology Day. This is pure mechanism and side effect memorization. Quiz yourself relentlessly. Differentiate the tissue-specific agonist and antagonist effects of tamoxifen, writing out why it causes DVTs and uterine bleeding. Then recite the massive toxicity profile of isotretinoin, specifically detailing the strict two-form birth control and monthly testing rules of the IPL-D CHEP program.
If you follow that specific schedule, you will transform these massive, abstract biological concepts into hard, instantaneous recall during your exam.
But before we sign off, I want to leave you with a deeper conceptual thought drawn from the pathology texts. Something beyond rote memorization for a multiple choice test, something to mull over as you study the underlying rules of human biology.
I love these. Let's hear it.
Consider the profound paradox of DNA repair. We know that acquired defects in DNA repair genes, like a mutated p53 tumor suppressor, are the driving force of cancer. They allow mutations to pile up unregulated, massively increasing your risk of developing a lethal malignancy.
Right.
But those exact same defects in DNA repair pathways are also the root cause of progeria-accelerated, devastating aging diseases. The very biological mechanisms that keep our cells from dividing out of control and forming tumors are intimately molecularly tied to how our bodies age, degrade, and eventually fail. It forces us to ask a terrifying biological question. Are aging and cancer fundamentally just two sides of the exact same cellular coin?
That is the kind of profound connection that makes you realize you aren't just memorizing facts for a test. You are studying the literal source code of life and death. Remember, when you look at that pathology slide and the diagnostic waters look murky, look for the basement membrane. Think about the timeline. Think about the mechanisms.
Good luck to you on your USMLE board exams.
Keep grinding, keep asking why, and keep diving deep into your studies. You've got this.